Assalamu alaikum wa rahmatullahi wa barakatuh. Our topic today is about hypoglycemia in diabetic patients. How to diagnose it, how to recognize it, and most important, how to prevent it occurring and how to treat it when it happens. First, we must realize that the brain relies almost exclusively on glucose as a fuel. But since it cannot synthesize or restore it, adequate uptake of glucose from the plasma is essential for normal brain function and the most important for survival. And that's why very effective physiological and behavioral mechanisms normally prevent or rapidly correct hypoglycemia when it happens. Now, what about the causes of hypoglycemia? We have two main categories. The first is iatrogenic, meaning drug-induced hypoglycemia, usually in patients who use hypoglycemic drugs like insulin or sulfonylurea drugs, and this is the most common category. The second type is spontaneous hypoglycemia in patients with tumor of the pancreas called the insulinoma secreting insulin, and this is very rare tumor actually. In this lecture, we will be discussing in detail hypoglycemia in diabetics. Normally, there is a balance between two types of hormones. The first is insulin, which tends to lower the blood sugar, and what we call the counter-regulatory hormones, including glucagon, growth hormone, cortisol, and epinephrine, which all of them tend to increase the blood sugar. First, for insulin. Functions of insulin is mainly to decrease the blood sugar through different mechanisms. It decreases hepatic glucose production by diminishing both glycogenolysis, which means breakdown of the glycogen to glucose, and gluconeogenesis, which means the production of glucose from non-carbohydrate source like amino acids, especially alanine, and from glycerol also. The second mechanism, it increases the glucose uptake by skeletal muscle and adipose tissue. The last mechanism is that insulin inhibits glucagon secretion by direct inhibition of the glucagon gene in the pancreatic alpha cells, resulting in more decrease of the hepatic glucose production. As regards the counter-regulatory hormones, let's start with glucagon, which acts on the liver, increasing glucose production by glycogenolysis and gluconeogenesis. The second hormone is the epinephrine, which has exactly similar effect on the blood sugar like glucagon. The third is the cortisol, and the fourth is the growth hormone. And in this figure, we can see clearly how this happened. We can see that epinephrine and glucagon will act on the liver in two different ways. The first is increasing the breakdown of glycogen into glucose, and the second is the production of new glucose from other substrates like amino acids and fatty acids and glycerol. This new produced glucose, or the one resulting from breakdown of glycogen, will go to the blood, increasing the blood level of glucose. Now, as for the definition of hypoglycemia in the diabetics, it is agreed that if the blood sugar is less than 3.9 millimole per liter, which is equal to 70 milligram per deciliter, this is a hypoglycemia. Now, what are the symptoms of hypoglycemia? We have two types of symptoms. The first we call the sympathoadrenal symptoms, resulting from acute activation of the sympathetic nervous system with the onset of the hypoglycemia. And the other type we call neuroglycopenic, which result from decrease of glucose supply to the brain, resulting in malfunction. Let's see. In this table, you can see these two groups. As regards the autonomic or sympathoadrenal, symptoms like sweating, trembling, pounding of the heart, hunger, and anxiety, all of these symptoms happen. As regards the neuroglycopenic, we have delirium, drowsiness, difficulty of speech, inability to concentrate, which may be the earliest manifestation. Also, there is incoordination, there is irritability, there is anger, meaning, especially in the older people, it can present with what be mistaken for psychiatric manifestation. There are non-specific symptoms associated like nausea, tiredness, and headache. As we can see in this figure here, this one with hypoglycemia complaining of multiple complaints, being hungry, having headache, sweating, confused, dizzy, with tremors, that is shaky. Now hypoglycemia is divided into 3 grades, 3 degrees of severity. We have the mild hypoglycemia, defined by the ability of the patient to detect and treat hypoglycemia by him or herself. Patient will be aware that he has lowered the blood sugar and will manage to correct it by himself. In the second grade, or the moderate hypoglycemia, the patient cannot help himself here. It is more severe hypoglycemia, and he has got to be helped by someone else. But still, he can be recovered by oral means. He can be given sugary juice, he can drink, he can swallow. In contrast to the most severe or severe hypoglycemia, or grade 3, the patient is unconscious or has convulsions or even conscious, but he is unable to take oral glucose because being extremely disoriented. And here the only therapy will be to give drugs to recover him, either glucagon or glucose, which as we'll be describing soon with the treatment. Now we have 2 different mechanisms to correct hypoglycemia when it happens. And the response to hypoglycemia is different in normal subjects from the response in diabetic subjects, as we will see. In normal subjects, there are main mechanisms. First, when the blood sugar starts to drop, there is suppression of secretion of endogenous insulin from the pancreas. With more severe degree, there is a release of glucagon from pancreatic alpha cells, which, as we said before, will increase glucose production by the liver. Then, with more severe hypoglycemia, the reactivation of the autonomic nervous system, mainly the sympathetic system, with the release of catecholamines. This is meant the epinephrine or adrenaline, which systemically and within the tissues will act to increase the blood sugar as well. And then we have what we call the stress hormones like cortisol and the growth hormone, which will be only secreted if hypoglycemia persists for several hours. It is not immediate release like what happened with the epinephrine, for example, or glucagon. In this figure, you can see clearly that there are grades, there are severity grades of the hypoglycemia with different response. As we defined hypoglycemia by blood sugar 70 milligram per deciliter or less, we'll see here clearly that even before reaching this level, if the blood sugar drop below 82 milligram per deciliter, there is inhibition of the endogenous insulin secretion. We remember well that insulin is decreasing blood sugar. Here, suppression of insulin will prevent any further decrease of the blood sugar. If this is not enough and the blood sugar drops more to 70 milligram per deciliter, the next step is that counter-regulatory hormones we just discussed will be secreted, namely glucagon and catecholamines, which we mean here adrenaline or epinephrine. The onset actually of autonomic and neuroglycopenic symptoms like confusion, irritability, disorientation will be at level of 50 to 60 milligram per deciliter. Severe cognitive dysfunction, in which the patient still conscious but even cannot help himself, with blood sugar less than 50 milligram per deciliter, and with very severe hypoglycemia with the blood sugar less than 30 milligram per deciliter, there is coma and there is convulsions. As we said, the actions of the counter-regulatory hormones in normal persons aim to reduce the whole body glucose uptake, to be conserved for the use of the brain. Number two, it will increase the hepatic glucose production from the liver. And it is important to realize that for these counter-regulatory hormones to work properly, the liver function must be normal. You do not expect a patient who has hypoglycemia in presence of liver cirrhosis and hepatic failure to recover spontaneously, since his this counter-regulatory hormones will not be effective as the liver is not functioning well. It is very important to remember treating such cases in patients with hepatic failure. You have to interfere early than usual because the compensatory mechanism will be defective here. In addition to these counter-regulatory hormones, there is what we call a behavioral defenses, meaning that with the initial symptoms of sweating and anxiety, palpitations, hunger, and tremor, which usually happen when the serum or plasma glucose drop below 55 milligram per deciliter, or which is equal to 3.1 millimole per liter. These symptoms will stimulate the ingestion of food. Patient will feel hungry. He will go immediately to have food. The mediator mechanism for this is the stimulation of the sympathetic neural activity, which will stimulate the desire to have sugary fluids or carbohydrate to correct the hypoglycemia. This is very important part, as we will see later on, in how this corrective responses in diabetic patient happen. In this figure, we can see clearly these actions we just described. The defense against hypoglycemia in normal persons. Blood sugar here, if you can see, dropping down. Then, the first of all, there is suppression of insulin secretion. And with more severe degree, glucagon secretion will start, followed by epinephrine and norepinephrine as well. Last of all, growth hormone and cortisol. All these counter-regulatory hormones will work to increase the hepatic glucose production to correct the hypoglycemia. Now, what about diabetic patients? Can these counter-regulatory hormones protect them? Let's see. Let's take, for example, first we said that the first thing is to suppress insulin secretion. In diabetic patients, especially with type 1 diabetes, who are dependent on injections of insulin, they cannot regulate insulin. Once it is injected subcutaneously, it is inside the body. Even if there is hypoglycemia, it cannot be taken back. So this step is not working for them. Insulin is still in the body, it cannot be suppressed, and it will continue to act despite the development of hypoglycemia. This is the first thing. So even with hypoglycemia, the injected insulin will still work and will decrease the blood sugar more. What about glucagon? It was found that in people with type 1 diabetes, within 5 years of diagnosis, most patients will have lost their ability to release glucagon, specifically during hypoglycemia. Same deficiency will happen to patient with type 2 diabetes, but after a longer duration. So, the diabetic patient has lost his secondary protective mechanism. First, he cannot suppress insulin already given from the outside. And second, he cannot secrete glucagon. Third, what about epinephrine? The epinephrine response to high hypoglycemia also becomes attenuated in many patients, partly because of repeated antecedent hypoglycemia, causing defective glucose counter regulation associated with 25-fold increased risk of severe hypoglycemia. What does this mean? It means that the sympathetic stimulation, which is part of the corrective mechanism of hypoglycemia, is defective in diabetic patient. How it becomes defective? With repeated attacks of hypoglycemia, the threshold for release of the epinephrine and norepinephrine becomes lowered more. For example, if at 50 and 50 or 55 milligram percent of blood sugar in a normal person, when sympathetic stimulation and adrenaline and noradrenaline is released in diabetic patient with repeated exposure to hypoglycemia only at level of 40 or 35, when sympathetic stimulation will happen. The threshold is getting down. Remember that we said that severe hypoglycemia with its CNS severe manifestation like coma and convulsion happen at about 30 milligram per deciliter of blood sugar. So if you lower the threshold for the correction, you are putting the patient in the dangerous area, putting him in the range of severe hypoglycemia, and this risk is increasing with time. With losing of the sympathetic activity of the patient, there is an estimated 25-fold increased risk of severe hypoglycemia, which is very dangerous situation for the patient. The last thing which is contributing to the problem of hypoglycemia in diabetic patient is the attenuated sympathoadrenal response, causing hypoglycemia unawareness, which is associated with 6-fold increased risk of severe hypoglycemia. One thing which we just said, which is important, that sympathetic stimulation serves two functions. The first is that adrenaline and noradrenaline release will help mobilize or increase blood sugar production by the liver. The second important function is that it will give symptoms which will give awareness to the patient, make him aware that he is having low blood sugar, like tremors, like sweating, like palpitation, awareness of the heartbeat, like feeling hunger itself. When this sympathetic stimulation happens in normal person, there is what we call the behavioral defense mechanism. The patient will immediately get some food, get some carbohydrate to correct the symptoms he feels it. But problem with long-standing diabetes, especially type 1, sympathetic response is attenuated. It is decreased. It is less than normal. So hypoglycemia will happen and will increase in degree with no attending symptoms. He will not feel sweating. He will not feel tremors. He will not feel palpitation. So he will not act to take some carbohydrate to correct it. This unawareness is very dangerous, which is again more and more increasing the risk of severe hypoglycemia. Now, can patient recover from hypoglycemia spontaneously? It can happen in the mild and the moderate hypoglycemia. In severe hypoglycemia, as we stated, the patient needs help, not even only by oral methods, because oral will not be suitable. Patient is unconscious or convulsing. He needs parenteral therapy. So recovery can happen only in mild or moderate hypoglycemia. but in severe hypoglycemia, it cannot happen spontaneously. Now, about what we call the hypoglycemia-associated autonomic failure. Repeated attacks of hypoglycemia causes defective glucose counter-regulation and hypoglycemia unawareness also, thus initiating a vicious circle of recurrent hypoglycemia, of which the patient will not be fully aware, precipitating severe hypoglycemia. Besides being dangerous in itself, this repeated attacks of hypoglycemia will induce more and more failure of the awareness of the hypoglycemia symptoms, and the response of the patient will be impaired more. This will happen by lowering the glycemic threshold for the sympathoadrenal response. Instead of being stimulated at say 50 or 55 milligram percent, it can only be stimulated at 40 or at 35, leaving the patient getting down with lower blood sugar, going into severe hypoglycemia. Now, to one variant of hypoglycemia, which is important, what we call the nocturnal hypoglycemia. Hypoglycemia during the night while the patient is sleeping. Actually, most episodes of severe hypoglycemia occur during sleep. Why? Because actually for two important reasons. The first is that the time of sleep is typically the longest period between meals. The patient has his dinner, say at 8 or 9, then breakfast next day will be only around 7 or 8, almost 11 or 10 hours. It's too long for a patient who is getting insulin to sustain his blood sugar. The sympathoadrenal response to hypoglycemia is reduced during sleep. So there is a long duration of fasting during sleep. Number two, the corrective mechanism, the sympathoadrenal response, is reduced during sleep, which makes the patient more liable to severe hypoglycemia. We have here a tragic syndrome. So it is rare, but still it is happening. What we call the dead in bed syndrome, which means there is sudden death during sleep occurring in otherwise healthy young patients. Patient who has no history of cardiac disease, patient who has no problem of his coronary arteries, completely normal as regards the cardiac function, but the patient found dead the next morning in his bed, especially patient with type 1 diabetes. The explanation here is that hypoglycemia during sleep will induce cardiac arrhythmia like ventricular tachycardia or ventricular fibrillation, and naturally the patient is sleeping. He will not be aware, will not give any manifestation so that he can be resuscitated. Only patient found dead at morning time. Now, how some patient can get symptoms of nocturnal hypoglycemia? They will not get the typical symptoms because they are unaware, but they will get some substitute symptoms like poor quality of sleep, having morning headaches, having vivid dreams or nightmares. Sometimes it's difficult for the patient to recognize that these symptoms are due to hypoglycemia. If he is lucky, a partner may observe that the patient is having profuse sweating while he is sleeping, or is restless, or twitching, or even he may have seizures if somebody is observing, so that he can be awakened and given the necessary treatment. How to diagnose nocturnal hypoglycemia? The only thing is that to measure blood glucose during the night to detect the hypoglycemia at that time. For this type of hypoglycemia, the advice is that patient with diabetes mellitus should be aware or be more concerned when they have blood sugar around less 70 milligram per deciliter and start to, even if there is no symptoms, to start taking some foods, carbohydrates in any form, as we'll talk about the treatment later on, to prevent the development of moderate or severe hypoglycemia. Now, how about prevention of hypoglycemia? What are the strategies adopted for this? Let's start with the glycemic targets. When we are treating any patient with diabetes, we have a plan. We are trying to reach a certain target of blood sugar with our control with the drug we are using, either insulin or oral hypoglycemic drugs. In patients with repeated attacks of hypoglycemia, we should have a less strict goals. This means that usually we are trying as much as we can to keep the blood sugar as near normal as possible to decrease the incidence of complications on the long run for the patient. But if the patient is having repeated attacks of hypoglycemia, we cannot do that because hypoglycemia in itself can be fatal. What we'll do here is that we'll be going up with our target to decrease the incidence of hypoglycemia. This strategy can be done for certain groups of patients with repeated hypoglycemia, especially if they have certain associations or comorbidities, like, as we said, repeated attacks of hypoglycemia in older people with limited life expectancies, since the target of near normal blood sugar giving benefit on a long run. They don't have a long time to realize this. No point in trying for strict control for patient who has expectancy of 3 or 4 or 5 years, since the danger is more, the risk is more than the benefit expected. This same also applies to very young children and as I said, on older adults. Also patients with other comorbidities, since they can be affected more by the hypoglycemia, like patient with associated cerebral vascular disease or patient with ischemic heart disease. All this should be put on consideration while deciding on the target blood sugar for their control. Now about the insulin regimen. It was found that using some regimen will decrease the incidence of nocturnal hypoglycemia, like the use of a basal insulin night dose and the repeated pre-meal bolus injections with rapid-acting insulin analogs. The education of the patient is very important. It is fundamental to the prevention of hypoglycemia. Patients should be aware about the risk factors and what's the treatment, what he should do. And the most important, patient should recognize hypoglycemia symptoms when it happens so that he can take the proper action. Importance of regular blood glucose monitoring and the need to have glucose and glucagon injection readily available should be also stressed. If there is a hypoglycemia unawareness, we just discussed before, we should take some action, which includes 2 to 3 weeks period of careful avoidance of hypoglycemia. As this period of no attacks of hypoglycemia happen, this will restore awareness again. The sensitivity of this sympathetic adrenal stimulation will be regained with higher threshold for detection, but to have this, we might need to be more relaxing the control to the point of having even permissive hyperglycemia for some time to get the hypoglycemia awareness situation. As for prevention of nocturnal hypoglycemia, the use of insulin pump that stop infusing insulin for up to 2 hours when the sensor detects a predetermined low glucose level. For example, if the sensor detects blood sugar is 82 mg/cent, it will stop the insulin pumping to the blood of the patient, simulating what happened with endogenous insulin, suppression of the secretion. This is what we call the threshold suspended feature of the insulin pump, and it was found actually that this method will reduce the nocturnal hypoglycemia. Now, what about the actual treatment of hypoglycemia? Patient with asymptomatic or symptomatic hypoglycemia should ingest carbohydrates. 15 to 20 grams of oral glucose is typically sufficient. Glucose may be ingested in the form of tablets, of juice, milk, or other snacks, or taking a full meal. Here, actually, when there is hypoglycemia, no point about too much strict control. It should be corrected first. In this figure, you can see the usual advice we are giving to the patient. If there is hypoglycemia and the patient detected, we advise him to eat or drink about 15 grams of fast-acting carbohydrates like glucose powder or 1 tablespoonful of honey or jam, fruit juice or soft drink, and recheck blood sugar after 15 minutes. If the blood sugar rises above 70 milligrams per deciliter, he should have a light snack of carbohydrates. But if the blood sugar is still less than 70 milligram percent, he again should be take another 15 grams of carbohydrates and wait for another 15 minutes to recheck blood sugar. What about treatment of severe hypoglycemia? If we have hypoglycemia in a person with impaired consciousness, naturally he cannot help himself. He cannot swallow. We cannot use oral methods to help him. We have two situations. If there is no established intravenous access, we use glucagon 0.5 to 1 milligram subcutaneous or intramuscular. We cannot and we should not wait until to have vascular access. We should use glucagon first. If the patient has established intravenous access, naturally we'll give dextrose. Usually 25 grams or 50% dextrose is sufficient. The other important thing here is that if parenteral therapy is required, then as soon as the patient is able to swallow, glucose should be given orally. Why? Because we need, beside recovering the blood sugar level of the patient back to normal, we need to build up the glycogen in the liver, which already has been consumed before the patient passes in severe hypoglycemia. And it can be best recovered or rebuilt with the oral carbohydrates. So the patient should have a carbohydrate meal orally, repeating orally to correct the loss of the liver glycogen. One important to notice here is that full recovery may not occur immediately after resuming blood sugar back to normal. And the reversal of cognitive impairment may not be complete until 60 minutes after normoglycemia is restored. We have to be patient and observe. The other important thing here is that when hypoglycemia has occurred in a patient treated with long-acting or intermediate-acting insulin or a long-acting sulfonylurea like glibenclamide, the possibility of recurrence should be anticipated. Why? The drug is slowly released in the body. Patient developed hypoglycemia, you give treatment, patient recover, the drug is still in the body and still will be released, and if you not sustain blood sugar more for a longer time, patient can have recurrence of hypoglycemia. And to prevent this, infusion of 10% dextrose, of course, titrated to the patient blood glucose, or giving more carbohydrate orally should be necessary. And observation for a longer time until we are sure the drug has no more effect and the liability to recurrent hypoglycemia is not there. This concludes our discussion for today about the hypoglycemia in diabetic patient. I hope the explanation is clear. And if there is any questions about any points in the lecture, please leave it in the comments. The other thing, if you feel that this lecture has been helpful to you, don't forget to comment on it, give it a like, and share it to other colleagues so that they can have a benefit also. And if you are not already subscribing to the channel, don't forget to subscribe and hit the bell button to be notified of all coming lectures. Thank you very much for your attention. I hope I will be seeing you in the next lecture. Wassalamu alaikum wa rahmatullahi wa barakatuh.